Hello and welcome to our COVID-19 respiratory update. We ran this session in January, but unfortunately our recording didn't really go to plan and wasn't going to be particularly suitable for YouTube. So I'm just recording a voiceover with the PowerPoint that we used to support our presentation. We had contributions from Claire and Jen during the actual teaching, and I'm just going to refer to some of the experiences that they talked about as I go through some of the slides. So the aims of this session were to increase the understanding of common COVID-19 presentation. We're going to talk about some of the symptoms, the assessment findings and the physiotherapy problems, increase the understanding of physiotherapy interventions that are appropriate for ward-based and critical care COVID-19 patients, and talk about the physiology even of gas exchange and ventilation in COVID-19, referring to optimal positioning, which we're using a lot with our patients throughout the hospital, whether they're ventilated or self-ventilating. So this is just an overview of some of the main problems and challenges that we had with some of the COVID patients on the ward environments and what we found in some of the assessments. So I'll just talk through this and refer to some of the things that Claire Shuckler talked about when she was presenting. So one of the big things was that patients are very, very breathless. Lots of our patients have been very symptomatic with their breathlessness. Some of our patients weren't so breathless, but had extremely low oxygen sats. So Claire referred to seeing a vast range of severities, and that I agree with that from when I was working on ResMed in the first wave. Some patients were needing little or no oxygen, through to some patients who were on 60% Venturis or non-rebreathe masks. And there could be quite a rapid change in somebody's oxygen requirements where they're quite quickly deteriorating and going up on their oxygen requirements. It's quite a low threshold to decompensate on minimal exertion. So we were finding that even sitting out of bed would cause people to desaturate quite significantly, or some of our really severe patients would desaturate even just on rolling and moving within the bed, and we were very limited as to what we were doing. So one of the big challenges there was balancing what these patients were doing on the ward and what the nursing staff were encouraging those patients to do. Typically, we were used to pushing patients, getting them up and moving and getting them going as quickly as we can. Actually, we had to really take a step back and slow these patients down, particularly some patients who felt like they could do a bit more and wanted to be getting up. We saw that their oxygen requirements went right up and their recovery might be quite slow while they were doing that. So we were trying to limit what they were doing and working alongside the nursing staff to demonstrate that could be tricky at times. We used optimal positioning with a lot of the patients on the wards, and we'll talk a little bit about the problems we might have with that in terms of patients being quite frail, musculoskeletal problems limiting their ability to prone. One of the really important things was to try and use side lying instead if somebody was struggling to get into the prone position. Secretion retention could be an issue, but not quite so much. Usually they had quite a dry, irritable cough, and that might make them more breathless as they were coughing and cause desaturation. We tended to find secretions when we had these secondary bacterial infections, so perhaps if you've got somebody who stayed a bit longer developing a superadded infection, that was something we were watching out for. Fatigue was a big issue. Patients fatigued very quickly on doing minimal exertion. And one of the challenges of working on particularly the respiratory medicine wards was patient ceiling of care. We had a lot of patients who would not have been for intensive care, and we had beds on ARCU for CPAP, but those patients weren't going to be progressing any further and spent quite a lot of time on CPAP, and then unfortunately weren't succeeding and weren't getting better and passed away. We were expecting to see lots of patients with existing conditions like COPD, neuromuscular conditions. Kind of thought these patients are really frail, they're going to be really susceptible to COVID, and then they've got this, they've got a background or something, which means that they're going to be really difficult to treat and really going to suffer with COVID. In the first wave, we weren't seeing those patients at all. In the second wave and now into the third wave, we are seeing some of those patients coming through. So understanding their normal symptoms and how trying to decide how much of what's going on is a cause of the COVID or a cause of their usual condition can be tricky. In terms of assessment, the respiratory medicine team are picking up patients when they're on 4 litres of oxygen or more and screening those patients by assessing their oxygen requirements, their work of breathing, and looking at optimal positioning. So rather than screening, I suppose assessment is more appropriate because they are seeing these patients face to face. Some of those patients might need just the one intervention, others would need further input. On the O drive in the ResMed folder, there's information about the assessment that they carry out and the sort of criteria they're looking at. One of the important things is looking at when the patient's symptoms started and what their swab date was. We were seeing quite a lot of patients who 8 to 10 days into their symptoms, that's when they were starting to deteriorate. And I certainly remember patients from the first wave when we were learning a lot about this condition, where in that first week I thought, oh, they're doing quite well, and you're starting to progress them, and then kind of 8 to 10 days in, you see that they have a real setback, and that was quite difficult to manage because we were wondering, had we done too much with them? It was really difficult because we were still learning at that stage. Assessing their comorbidities, so we see that a lot of patients with diabetes, hypertension, cardiac history are high risk. We're seeing some of the patients with asthma coming through as well. So those patients are more likely to need our input. And then we would use the optimal positioning guidelines, which we're going to refer to a bit later on in this presentation. Assess their oxygen requirements initially, and then get them into the optimal position. So that may be in prone, but we're actually finding really good success with side lying as well. In terms of assessment, not necessarily using auscultation, we weren't always able to take our stethoscopes into the areas where we're treating COVID patients, and actually it wasn't necessarily adding very much to our assessment. Palpation could tell us quite a bit about whether somebody had secretions. Really important thing was observing their breathing pattern and their work of breathing, what they were like when they were talking to you, what their stats do when they're moving or when they're at rest. An accurate respiratory rate. Definitely count your respiratory rate. A good tip is, if you've got one of those OBS machines with the thermometer attached to it, you can press the little clock button on there and it'll count you down for a minute and beep every 15 seconds. So you can count someone's respiratory rate even if you haven't got a watch or a clock to hand. We're typically seeing patients with respiratory rates in the 30s and 40s, and actually those sorts of things were telling us more than sort of listening to their chest, which was a bit different from what we're used to, where we probably listen to people's chests quite regularly. Checking their blood results to see if they've got an infection as well, and also looking at the chest x-ray, which we'll come on to. They were seeing a correlation between quite severe x-rays and high oxygen requirements and those patients that desaturate on minimal exertion. Claire talked in our training session about somebody who had responded initially quite well to prone position and tolerated it very well, but then the following day had deteriorated a bit further, and even on turning her head was desaturating, and this was somebody who'd had quite a severe x-ray as well. So those pieces of the puzzle were all kind of fitting together. Some of those patients on the wards are, particularly in the respiratory medicine area where they can step up to ARCU, it's appropriate for them to go for CPAP, and they were trying that quite early. And we were seeing patients who had quite prolonged periods on high oxygen. Once those patients started to improve, then looking at weaning the oxygen and assessing the patient on exertion was really important. So more specifically about some of the treatment options for these patients. Oxygen, big thing, looking at whether they've responded to prone positioning, whether we can titrate that, so whether we can wean it down. We can't necessarily wean it when we've got the patient positioned, so they have tolerated prone position. We can't always wean it, because if they're then going to move and sit up again, you do see that they drop their sats, so it might be best to keep them on that oxygen, unless you can monitor that quite closely. Once they're improving, assessing on mobilisation and titrating oxygen. You might have some patients that then don't need oxygen at rest, but do need oxygen as they're starting to mobilise. Considering nebulizers, if that's appropriate, mucolytics like carbamazepine for some of the patients who are normally productive. We've already talked a bit about encouraging early self-proning and optimal positioning, mostly for oxygenation, but we obviously see some benefits for postural drainage as well. Some of the patients who have issues with secretions, we're using manual techniques or active cycle of breathing, and that's been more prominent in the second and third waves, when we've been getting some of the patients with more respiratory problems in their background coming forward, where we didn't really see them in the first wave. Lots of education about breathing control, how much to push themselves, reassurance about the disease process, which has been quite difficult when we've not known much about that, but as we see a bit more, we can advise patients about not pushing themselves too much. Some patients, it's been indicated to use adjuncts like Clearway and Bird, where these devices are aerosol generating, so using the appropriate PPE. You might also need to liaise with a ward manager in the area about where those patients are. We typically weren't using those devices in an open bay, and sometimes had to facilitate moving a patient to a side room for those sorts of treatments. So some of the kind of take-home tips from the ward patients is assessing patients even when they look to be on sort of fairly minimal oxygen, considering early proning and optimal positioning, bearing in mind that side lying can be just as effective as prone if your patient can't get into prone, and we can play a really big part in this, where it sounds like you're just saying, oh, just lie on your front. Actually, a lot of patients need more than that, and I certainly saw some patients who had been advised to lie on the front, and without a full explanation and assistance with, let's get this pillow in sort of by your arm so you can relax quite comfortably, they weren't able to do that effectively and didn't sustain the position. Some patients where you're getting them on the side might be prompted to sort of lie more towards their front on their side, where they're hugging a pillow and they're right over, as opposed to somebody going, oh, lie on your side, and shoving a pillow behind them. Played quite a big role in educating nurse and staff and patients about this. Being aware that patients can quickly and easily decompensate, we need to slow down and be quite cautious with these patients, and using supplemental oxygen for assessing movement, checking SATs regularly is really important. So moving on to talk about ICU patients, Jen Smith kindly shared her experiences with intensive care patients when we presented this over Teams, and Jen had worked through all waves of COVID. I've now joined the Lincoln Wing team in the sort of second, third wave, and had experience with ICU patients as well. There was differences from the first and second waves really, where in the first wave we were probably waiting longer on high levels of oxygen, and then putting people on CPAP, but patients were probably tubed more early than they are in this current wave, where we're holding off because we didn't see any more beneficial results by ventilating patients early as to trying to avoid ventilation. So this time patients are being intubated, sometimes on a more elective basis, where they've been on CPAP and NIV for a couple of days, sometimes even a couple of weeks, and then having discussions about ventilation. Unfortunately, we're still experiencing quite poor survival rates, and that's something that the patients are being made aware of, which can be a terribly difficult thing and quite distressing. What we found in the first wave was that because we weren't using the wet circuits on the ventilators, initially there wasn't much of a secretion load, but then we were getting thick secretions because those secretions were needing much more humidification. So you're trying to use lots of saline to shift things, and plugging off was a bit of an issue in the first wave. Now we're actually using the humidified circuits again, and that is less of an issue, though we do find patients are becoming productive once they've been ventilated for a few days. Needing incredibly high levels of sedation and often paralysis for patients because they will breathe on top of the ventilator. So we then find that they don't have a cough, and it can be even harder to clear secretions. So sometimes we are working in pairs to vib while we're suctioning, perhaps using a head down position when somebody's proned, and again lots of saline sometimes. In the first wave there was blockages of the ET, partly because of this thick sputum when we weren't humidifying the circuit. As patients remain ventilated longer, there is a higher risk of secondary bacterial infections, and we do see some patients that seem like they're getting better and then take a massive backward step, and it's not always clear whether that's a secondary infection or whether that's the sort of relapse of COVID, but we're sometimes seeing patients look like they're improving and getting away with not being ventilated and then needing ventilation. The pressures that are required to ventilate patients tend to be very high, and that often limits our intervention, and these patients can be quite unstable, and we are tolerating higher CO2 levels. We're seeing very high CO2 levels in a lot of these patients. In terms of our assessment with the ventilated patients, initially we weren't really auscultating, but we are probably going back to that quite a bit more now. But those auscultation findings don't always fit with everything else. So palpation is quite important. Sometimes you can feel stuff that you weren't hearing. Using the ventilator waveform analysis, so looking for irregularities on your flow when you might have some secretions present in the airways that we're not picking up on auscultation. Some of these patients, again, observation of breathing pattern and their saturations is really important, particularly when they're still trying to breathe quite hard on top of a lot of sedation. We have people on quite high levels of propofol, and you see that they're still working very hard, and their respiratory rate can be 40 or 50 on the ventilator. And then looking out for their blood results as well to see if there is anything else going on with an infection. So the treatment options we've had available to us, again, once we're starting to wean people, looking at their oxygen therapy, and some of the patients that are coming to us for high flow and CPAP, not needing ventilation initially or at all, we're titrating that appropriately. Often what we find is the flow is really important. So patients are coming to us for high flow, they may be having alternate high flow and CPAP, and they're having breaks off the CPAP on high flow. They need quite high flow to maintain their saturations and not feel that sort of air hunger they're getting. So for some of those productive patients using nebs and mucolytics, again we're using early self-proning, so patients on high flow and CPAP as well, we're trying to get them on the sides or in prone if we can. Often find a bit of a challenge in proning if they're wearing a CPAP mask or a CPAP hood. It can be done, but we do sometimes find that the patients aren't comfortable with the mask. We are proning a lot of patients who are ventilated, and they need to stay in that position for around 16 hours to have some effect from that. Our usual treatments for secretion clearance, so using manual techniques, installation of saline, quite important when we're thinking about tube patency with those thick secretions. It's possible to use the ventilator for an inspiratory hold, and where we've not been wanting to take people off a circuit with very high peak pressures, we might think about using ventilator hyperinflation. And again, we might use adjuncts where we are using adjuncts where those are indicated, and the clearway is being used a bit more in this wave than it was in the first wave with ventilated or trachea patients. Our sort of take-home tips from this is thinking about proactive treatment where we might have thick, sticky secretions. Definitely pre-oxygenate, or so either give an O2 boost or increase the FiO2 before you do some intervention. These patients can desaturate just on rolling, suction. I would always pre-oxygenate before you're suctioning, unless you know that patient quite well, but they can still be changeable, and they can desaturate quite easily on suction and then take an age to come back up again. So the best thing is to try and pre-oxygenate. Sometimes one of the challenges is that we're treating people on a high amount of oxygen, and our pre-oxygenation is not giving them, we're starting on 90% and we're giving them a boost of 100. It's not giving that much extra. Early proning and sort of trying to keep those secretions nice and loose. Just a quick slide about some of the typical blood results that we might see. We're not particularly seeing white cell counts raised unless we've got superadded infection, but we might see raised CRP, reduced albumin, reduced lymphocytes, and reduced eosinophils. Some of the other findings that have been noted clinically include a low PCT, so that would normally indicate some infection. We're often seeing, most of our COVID patients, that's quite low, unless they've got a superadded infection, and that D dimers are often raised, and we're getting lots of clotting issues with these patients. So certainly on intensive care, some of the complications we're getting with patients is large PEs, that in particularly we've seen that more in the second and third wave, and if somebody's suddenly deteriorating, that's something that is worth investigating. Thinking about the typical chest x-ray findings, we tend to see a bilateral picture, so unlike our sort of pneumonias that would be unilateral, we're seeing these sort of ground glass opacities, this really patchy presentation that we've got there, and particularly peripherally where the small airways are infected. So this is a disease that's affecting the alveoli, affecting the peripheries of the lungs, and we're seeing that sort of right to the edges on our x-rays and seeing some consolidation, but generally we're seeing a bilateral picture. It's important that we look out for other pathologies as well, because some of the complications we've seen with patients, particularly on intensive care, but also where they're having positive pressure, pneumomediastinum, pneumothorax, so and then other infections as well. So it's worth looking out for that and trying not to be completely blinded by the COVID that you see on the X-ray. We've included this image of the ICU treatment elevator to just put in context the levels of treatment and take ourselves back to basics really, and think about what we're doing with our patients. So initially we're assessing for secretion load using the normal assessment tools, suction for assessment where you think appropriate, assessing cough, assess the sputum if you feel that patient's stable enough. Starting out with positioning, as we always should do, so that we optimise our treatment, optimise oxygenation. Next step might be to instill some saline to aid clearance, make sure that they're on the appropriate things to help clear secretions like nebs and carbocysteine. Next up is our manual techniques, our VIBs and assisted cough that can help, particularly in our patients who are sedated and paralysed. If none of that's working, we're kind of looking towards things like ventilator hyperinflation, inspiratory holds on the ventilator. And as we're really kind of running out of options, we need to take time to have discussions with medical team about, it might be the stability of your patient and what sort of options we've got, where, often it's not appropriate to be doing intensive treatments that involve, or like manual hyperinflation that involves breaking the circuit, but whether clearway and things like that might be indicated. But lots of the management of these patients is used with these bottom elements of positioning, saline, suction, VIBs that we're also used to, and we're just taking it into a different context really. So one of the big things we've really had to rethink and go back to our university days and physiology and put this into context, possibly more than I feel like I ever have done before. VQ matching and thinking about the physiology of the ventilation for these patients. So this picture just sort of demonstrates VQ matching. The V stands for ventilation, which refers to the volume of air that's inhaled and exhaled. The Q, is perfusion, which is the total volume of blood that reaches the capillaries. So in an ideal world, we would be looking for a perfect match of good ventilation to areas where we've got good perfusion. In reality, we never get a perfect match, so our normal VQ is a ratio of 0.8 roughly. Where we've got perfusion without ventilation, we get a shunt, and where we've got ventilation without perfusion, we've got dead space. So there's always some areas of the lungs that are either getting good ventilation but just not having the circulation to pick that up, or areas that are well perfused but don't get good enough oxygenation. In a self-ventilating patient, this picture gives us an indication of where we're getting good ventilation and where we're getting good perfusion. So the picture of the slinky there represents our airways, and the alveoli in the upper region, so in an upright patient at the apex of the lung, those are less compliant. They're already on some stretch there, like those top springs of the slinky, and they can't expand much further. Towards the bases, those alveoli are a bit more squashed, but that means they've got potential to expand and take in more air. So you've got better ventilation there. In terms of our perfusion, gravity affects blood flow massively, so we've got better perfusion in the gravity dependent regions. So in an upright patient, just above the bases is where we've got that best matched VQ. What happens when we use positive pressure on a ventilator, or for some treatments like using the clearway or the bird, that air goes down the line of least resistance. The positive pressure is pushing that air in, and it's easier to get it into the places that are already half open. The alveoli at the bases take a bit more to overcome. So the perfusion remains the same, but we've created a bit of a mismatch. So on our ventilated patients, that can be a bit of a problem. This picture represents what's going on with the physiology. So we've got this inflammatory picture where we've got thickened membranes of the alveoli wall. We've got an inflammatory response, so in the alveoli and within the interstitial space. This means that the oxygen has much further to travel to get into the capillary network, and less of it's going to get there. So we're not getting a good VQ match. This slide's demonstrating what's happening in the supine position, where we've got saturated kind of gravity dependent areas where we're really not getting much ventilation going on at all, and it's like this sponge full of water in the gravity dependent regions that just can't take on good ventilation. In the sort of middle regions, we've got some areas where it's aerated, some bits are sort of fluid filled. We've got a mixture of how successful that can be, and what's really sort of responsible for the ventilation is what we refer to as the baby lung, which is the aerated part of the lung. So we've not got enough lung tissue really able to ventilate and perfuse well. So thinking about why we use the prone position, what we find is that the posterior aspects of the lung has a greater surface area when you compare it to the anterior aspect. This means you've got better perfusion. In supine, the heart is resting on the left lower lobe, compressing that and limiting ventilation. So you've got better perfusion, but you can't get the ventilation so well. And that CT showed nicely that there wasn't going to be much going on there. In prone, when you turn the patient over, the heart then rests on the sternum. The chest wall's then fixed against the bed, and the chest can expand better. Particularly the left lower lobe can expand more where you've not got the heart pressing down on it. Then you've got the well-perfused posterior aspects of the lungs, which can open up. Gravity will create more of that perfusion to move again, but what happens is you get a more even distribution, more homogeneous perfusion throughout the lung, and that leads to better VQ. So even when you've not got positive pressure, you've got better distribution of perfusion, allowing greater VQ matching. When we then add positive pressure, so our ventilated patients in prone position, we can then push air into those posterior alveoli more easily. We can also try and drain some of those secretions that may be more posterior. So some of the research coming out of Italy, where they scan a lot more of their patients, shows that patients who've got changes in the posterior aspects of their lungs respond better to prone. In reality, we're not actually scanning all our patients, so we're not going to be able to tell straight away whether they'll respond or not, and we just need to give it a go. This shows the optimal positioning guidelines that we've developed in Leeds, and lots of places across the country are doing something very similar. So there's a flow chart there which you can find in the optimal positioning guidelines and within the rehab guidelines, which are on the O drive. A few things to consider before you look at changing position, in terms of how, has your patient just eaten? Have they got any restrictions in joints, and any reason why they might not tolerate optimal positioning? Prone would be our ideal position, but that's not always possible, and we do find that we get good results from side lying as well. So there's a picture there of Dave modelling the prone position nicely for us, and here he is again in a few other positions. So this side lying position that we've got on the left has been quite successful, and where you've got patients who can't lie fully prone, that can be a good alternative. And you can also be encouraging people to go from one side to the other and think about their pressure areas as well. Sitting up in bed, if they really are going to be on their back and they're not wanting to move, get them right up, put some pillows under their arms so that they can fix more easily. And likewise, in a forward lean position, if they are well enough to sit on the edge of the bed, then they can get quite comfortable on leaning forward onto a table with some pillows there to relax into. Important to assess how they respond to these positions. You might be able to see what their SATs are doing, give them sort of 15 minutes there to monitor how they're going and see what you can do with their oxygen. But bear in mind that you often see an improvement while they're in prone or semi-prone, but then when they turn onto the back, their oxygen requirements might go up. Just to finish off, there's a few useful resources listed here. Our COVID rehab guideline and patient booklet saved on the O drive, and you can get printed copies of the patient booklet to aid patient education. There was a course running in the first wave, and I think again earlier this year, called the Remote Covid-19 ICU course. There's some presentations from that which are on the e-learning for health website, so go to that website and register with your NHS email. You can access those. There's also a lot of other COVID resources on there, some good resources produced from London and shared widely. In January, in November even, there was a physiotherapy update which was broadcast on YouTube, and those recordings have been stored there. So if you search for the AHP Leader channel and look for videos from the 7th of November, there's a few hour-long teachings about physiotherapy management, pathophysiology, ventilation, prone positioning, a bit more on VQ, but also some stuff about long COVID and longer term management. So if you're interested in those, they're really interesting to watch. And finally, we've just included a slide here listing some of the AGPs, and the best thing to do is check what's up to date in terms of advice on the O drive, but for all AGPs at the moment, we are wearing full PPE and FFP3 mask, but it's always a good idea to check what's happening in the area where you're working in terms of whether that patient needs to be in a side room for a particular treatment, or whether it's manageable within a bay. Anyway, I hope you find that useful. Thanks very much for listening.